Thank you for this panel. We have looked at data, we have looked at cloud as foundations for trusted innovation. And for our final roundtable, we're bringing the conversation back to those who ultimately decide whether technology has value. Those are obviously the healthcare teams that use it every day. So the next conversation moves to the front line because digital tools only matter if they fit into the real work. So the question here is very practical. How can technology support care without complicated? And to help me answer this question, I now invite to the stage in Garrett Studdard, National Clinical Lead for Urgent and Emergency Care at the NHS England. Can I please have Garrett come up on stage? Dr. Gurnak Singh Doshan, please apologies if there's any mispronunciation. He's the GP and Deputy Chief Clinical Information Officer for NHS Leicester. Dr. Bernardo Duque Neves, internal medicine physician at Hospital da Luz and member of the Portuguese Medical Association's AI Commission, and Sofia Correia de Barros, country manager of Diverum, Portugal. The discussion will be moderated by Alexandra Abreu Loureiro, partner and office head Portugal at Brunswick Group. Alexandra, the stage is yours.
Thank you very much. And hello to all, welcome to this third roundtable. Reality, not hype, is the theme we have for today. I've been told I have to hurry up because there is a dead zone between the last panel and lunch over there. And so I need to keep everyone at least interested before we dash off to lunch. So there is in fact a hype. AI is everywhere, is the buzzword. You've been introduced already, so I'll go straight into discussion. We obviously have a very varied approach to the sector. If I may, and interesting to hear, we heard about literacy today, the importance of literacy in fixing things or clarifying things in national health services, but also in private systems. We've heard about how tech and intelligence should go together. And I think an important part of the hype is what is administrative hype and what is really solving the problem on the day, on the moment. I probably will start with our own Dr. Bernardo and ask if that is the case and you sit on an AI committee, is that the way it's perceived? So beyond technology, how to go beyond the hype and how to make it normal and fix things?
Thank you so much for the kind question and for the invitation to be here. I think we're living in strange times where sometimes the reality can be perceived differently depending on the angles we are seeing. As a doctor, what I expect to see and what we are all eager to have is concrete solutions to help many of the problems that have been discussed today. So there's a big gap between the development, the building tools, and being able to measure their performance, their accuracy, and then translating this to clinical practice to solve actual problems. And so one of the interesting things I've been hearing today is that mostly we are, I think we are all, most of the doctors, all my colleagues will surely agree with me, we have experienced very traumatizing times with the electronic health records for many years, and especially for generations older than mine that start working without computers and then translated to computers. Most of the time people are still catching up with all the challenges that needing to have a computer puts. And it's very interesting that we are still talking about applying AI to solve the problems that this digitalization of healthcare introduces. Our aim should be to achieve better health and to optimize for the clinical outcomes that we want to achieve. And AI certainly can promise that, but at the same time, applying this technology to the everyday care and to help you make concrete decisions with the patient who is facing on you, it's still not quite clear how we translate from these promising, these performant tools to concrete solutions that can help you take solutions. We already seen great examples today of what we can aim for, but I really think we should be demanding and required for all the evidence that support us to do this in a safe way and in a proper way. Yeah.
Let me also say that all of you on this panel obviously will be expressing your personal views, not on behalf of the institutions and companies, both private and public, but as expert voices, you'll be giving us your personal view on these matters. And maybe I can turn to the NHS now. We are represented at both different regions from the UK NHS. Obviously, NHS bears a very important DNA flag for the UK. And automation and AI, in that sense, probably will need to deliver tangible improvements. So I'd like to hear from both of you, maybe we start with you, on what that would look like, tangible improvements.
So there's been digital advancements that have been happening gradually all along with sort of introduction of 111 online, as well as the telephony service. We've got the introduction of natural language processing to guide patients to the right setting. We're looking at pilots for how we can look at the lower acuity patients through AI to then steer them towards self-care and to some of the pharmacy first elements. I think that there's a lot of belief that AI is the savior. And people talk about an AI-driven triage app as part of the NHS app, but nobody's actually really defined what that is. And I think people have got this this vision that Claude or whoever is a real person and creating these answers for you behind the scenes, rather than the reality that it's a search engine and that we just need to put guardrails in there and to make sure that we're using that those guidelines, using the correct processes for all these new and burgeoning pieces of software or processes to introduce AI. I think it is inevitably coming. I think we will have to look at keeping the safety element there. There's a lot of belief and a lot of trust in the current system. It's got quite a legacy there. There is a belief that it is overly safe in our urgent care system, and that is contributing to some of the demand problems. So it is going to take some time for us to steer people away from that and to try to embrace something new.
So in a way, you know, the idea that AI or technology is not a replacement, but an enhancer to a better service. And I go to you, Gunnar. Do you think that is the view, or that should be better explained, really?
Yeah, no, first of all, thank you for having me here. And I completely agree with this point. We've got to make sure that what we're not doing is letting the tail wag the dog. What I mean by that is we often see lots of digital technologies that will come and will propose, hype, a solution to a problem which actually doesn't exist. And what that might then do is actually create more problems. So we've heard this many, many times before, but we really need to stress on this, that as leaders in your own right, we have to be fixing a problem. And that problem has to be a top priority problem, which exists right now and will continue to exist. There's a real risk that if we don't solve those problems, we are causing harm to patients, to clinicians, and the systems. Thinking about what we've done locally, and I am talking from my own viewpoint, but just kind of reflecting on what we've done locally, ambient voice technology has really changed how GPs practice. You know, for one time, I actually had a patient tell me, "What lovely eyes you've got," because normally I'm doing this. But I also had my friend's dad visit his GP once, and his friend said to him, "Oh, Dad, I didn't know you had a kidney problem." You know, he was looking back at his clinical records. He goes, "I didn't know you had a kidney problem, and I didn't know you had to have a kidney operation." And his dad goes, sorry, no, that wasn't what happened. And when he recalled back his conversation with his GP, he was talking about his cat who had a kidney problem, and the ambient voice technology had picked it up as his, and the GP was in kind of cruise mode and had entered this into the clinical record. So it just goes to show that if we're not careful, we can create problems instead of fixing them. And the final thing I just want to kind of touch on is the point that at this point in time, when we think about our clinical workforce, we think about our services, certainly locally, we are already running at 120%. So we are already doing more. Sometimes the hype is, we are now going to get you to do double. Actually, if I can just stop and have a pause in the day so I can go to the toilet, I'm really, really grateful. So there is something about the promise and the premise of what AI technology and automation is going to bring. And it doesn't necessarily need to be about big statements like, we're going to save X amount of money, or we're going to save X amount of time. Sometimes it's just about making sure that we can deliver better and safer quality care.
Yeah, I think the sense of acceleration is very palpable, very real. And so is the need for solutions and partners solutions. So I'm looking at the private sector with Sophia, who's CEO of Diabram in Portugal. And interestingly enough, this morning, the Minister of Health of Portugal published an op-ed piece in the media highlighting exactly that. So the private sector is a partner, not a competitor. How do you view that?
So first of all, thank you for the invitation. I like the perspective. I think that the private sector is a partner for the NHS, and in many sectors, and in particularly in hemodialysis where I work, we are a true partner in the sense that we treat 93% of the patients. So without us, the patients would not have a solution. I also believe that we are a partner when we point directions, like solutions that we start by developing. And in our case, and I'm proudly of the solutions that we have developed in Diaverum, we have developed prediction solutions that help to predict thrombosis. And we already have very good results. We have 20% of the thrombosis that were reduced due to this kind of tools. So even from a technology perspective, private providers can be a partner for the NHS as a whole, because they can contribute to the system by reducing hospitalizations, by reducing severe episodes.
Mm-hmm. So just to bring us back to the hype versus reality, but more importantly, how hype becomes normality. You mentioned guardrails, Gareth. You mentioned the cat and the kidneys, which I thought was a brilliant example. So I go to you, Bernardo, on the combination of guardrails, cats and kidneys. Let me ask you, in terms of those guardrails specifically, and as Sophia mentioned as well, sharing those data and those information, how does the technology also inbuild the solution that is at the same time resilient, safe, ready?
Mm-hmm. Yeah, that's an excellent question, and I think we can all agree that we are all still learning how to accomplish this. Not only this technology is all very new, but also all the legal environment is changing quickly, and so we are all trying to learn as much as we can to how to accomplish what you ask. I would frame this into ways. First of all, I think we need to be very clear when we are dealing with clinical care and applying technology to care, that one thing is to have technology that has all the legal requirements to operate. Other different thing is to make sure that this technology is being applied the right way and it are achieving outcomes that we want to achieve with this technology. And I think from one part we are still much on the developing era and trying to develop the wonderful solutions, but we are still very short in terms of providing clinical evidence of the benefit of much of this technology. Of course, we all agree that we will get there. This is all very new. There has been no time to validate much of the technology we have, but we should not lower our ban and our need to demand for technology to prove the value and to prove the economic benefit. On the other side, I would say that this is also very new for us doctors to understand how to interact with technology. And there's still a need not just to think how we'll change the medical curriculum. That's not topic at the moment, how to change it in order that we all learn how to deal with this technology, but to get a real sense on a daily basis on what are the limitations and the way that we should interact with this technology. Just a couple of weeks ago, we had this wonderful New England Journal of Medicine paper showing wonderful performance of AI technology, of generative models that would find much of the answers that doctors want, but at the same time, if you push them, they would give you a dosage of a drug named Pokemon. And so everyone understands that we need to deal with this. We are not used to deal with someone who does not know what's talking about and seems very confident about that. We can notice that right away when we interact with people, but with this kind of technology, it's very hard. It seems to be right most of the time, but we should be very aware that the possibility of errors exists. And the last word will, I think, be for a long time as a clinician. So we need to empower clinicians to actually be in the loop and not being spectators to what's going on.
UpHill really speaks for the fact that there is always a human in the loop approach for every solution in technology, which is something on the patient side, on the user side, I guess is what people also look for. In the NHS, and Gareth, maybe I can ask you that, there is, as in other NHSs across Europe, the demographics are important. Professor Peter Bach touched on this at the beginning of the session. Aging populations means more patients, means older patients, more and older patients trying to access through technology the NHS. There is a piece there to be resolved in terms of explaining how technology can support, not complicate, but before that, maybe explain how it can be used, like an A to Z of technology for these growing patient population in age?
I mean, from my experience, the aging population appear to be a lot more computer literate than we assume that they're going to be. And their embracing of technology and different means to contact and to engage with healthcare is surprisingly good. So I do think we have to be aware of sort of the computer literacy of the populations, but I don't think it's the big stumbling block. But coming back to the question of the increasing demand, yes, we have got an aging population, which does put a degree of an extra demand there, but we've got a different mentality in terms of people seeking healthcare. Whether that's by sort of change in family units, no longer living with the wise mother just around the corner, whether it's education, whether it's perception through the media as to
more individual, you mean?
Yes. So we've got more individuals that are contacting healthcare services, and I think that has in itself led to a change, a sort of a bias in clinicians in terms of what needs investigating. So if you're a GP, for example, and you're used to sending 50% of the highest, or the highest 50% off to somewhere else, if you extend the acuity downwards, you will start sending lower acuity patients that you previously wouldn't have done. And the same applies in A&Es. If younger doctors are seeing a lot of the lower acuity patients, they will start over-investigating the medium acuity patients. So I think that the thing that we haven't touched on so much, and I think all of the ways of improving efficiency are brilliant, but the processes and how it interacts with other systems is great. However, if we increase the efficiency, we're not necessarily going to have time to go to the toilet. We're simply going to let more patients through the door. So I think that to me, the way that we need to embrace this increasing demand is to look at how we allow patients to have that autonomy back, their own decision making, rather than assuming that everybody needs an assessment.
So I assume prioritizing or letting people know in a clear way what prioritizing can look like would be helpful?
Not necessarily. Well, prioritising those that do need care, but as Eduardo said at the beginning, the sort of intelligence leading to action. I think there's a large proportion of the population that intelligence and education can lead to inaction, and that these patients, given the right information up front, they can self-assess, they can decide what's best. If we force them down an assessment route, then they will invariably reach a higher acuity outcome than had they made that decision themselves. So I think that's to me to address the pressure issues within urgent care. It's how to turn the tap off rather than how to increase the flow through the plug hole.
But how do you do that? And it's a simple question, but it's a very direct one to either of you. So how do you do that? Because you are empowering people, but the doctors are still there also for that. Or at least the user will look at the doctor and say, so what's the priority? I may not know as a user.
Yeah, so I mean, within the 111 service, we have been directing patients towards information videos at the front end. So not after an assessment, they will call up and are you calling about RSV, for example? We sent then a link for a video, and it allowed about 30% of those that received the video to self-serve. Okay. So they weren't needing it. As a GP, I send information. Yes, it's coming from me as a GP, but I'm not really assessing the patient. I'm sending the links, and it satisfies them. I think we need to look at how we can get some consistent info assessment processes that allow that patient the knowledge and the education that they would previously have got from their mum or their grandma or some other neighbour, which they've now lost.
So it's a nice way to put it, is to have AI replace your mother or grandmother. I think that works. Is that what you're also a practicing GP, right?
I am.
Is that what you see? Is there an appetite for replacing your mother for AI sometimes is useful?
My mum, personally, no. Just before I answer that, though, I'd like to come back to a point that you made around age. Okay, and that age is not the only protected factor that we need to think about in terms of equity. And I'm fairly sure that this is a universal problem. But we have different cultures, different languages, different kind of social economic backgrounds. And all of those different variables come with their own unique challenges. Now, one of the challenges that I think about, so when a company comes to me and the first thing they say to me is, we want to fix X, that is our project mission. And I will say, okay, that's great. That's really, really good. You know, it works. Let's say, for example, it's about cancer. And I'll say, that's brilliant. That's exactly what we need to focus on. So how are we going to do that? And then they tell me that they've got this fantastic tool which was trained on a particular group of individuals that does not represent the patient population that I serve. And actually what they've done is they've created a model which works for the 20% of the easiest individuals that are already accessing healthcare services. And so if the products we are creating is not representative of what we are trying to kind of fix, we're going to miss out, and we're going to actually widen health inequity. We're going to make it harder for those people that aren't meeting us. So the next question should be, well, how do we solve that? And what we have to do is we have to make sure that AI and automation does not become the next SATS oximeter. Who knows what I'm alluding to there where I mentioned SATS oximeter? Just a show of hands. Okay, so not many people. SATS oximeters, so these are the oxygen meters that check your oxygen levels. They were really used widely during the pandemic. They do not work well on people with skin color like mine or darker skin tones, and probably somewhere in the range there. So there was a real inequity there. So we need to make sure that when we are designing these tools, first and foremost, when we are implementing these tools, secondly, we need to make sure that we look around the room. It's really simple. And if everyone looks the same, you're going to miss a trick. That doesn't necessarily need to be in color, but if everyone's, in their 30s, all white and all male, you might miss a trick because you've not got those voices in the room to say, this is what we need. So coming back to the question, is replacing mum, grandma, another stoical person, a valuable proposition? It absolutely might be for certain populations. But for other populations, certainly where I work in Leicester, we still have extended families. So, who live, 3 or 4 generations in one household. So that value proposition just wouldn't fly at all. So we really got to really get down to what the nub of the challenge is, what the nub of the problem is, if we really want to start scaling up above and beyond little pilots.
So scaling up is the theme of today's discussions. And Sophia, I'll take you as a practical example because you cover a very specific health sector. Everything we've been discussing here, from finding solutions to stumbling on blocks and trying to fix those via scaling up AI and digital tools, is that what you're seeing specifically in your sector? And how is it overcome? And how can people come in and specifically say, well, I used to do this face-to-face, now I can do it via an app before I come to the face-to-face. Is that working? Is that the feedback you're getting?
So, good question. I think that we don't have a single answer for that question because we have different scenarios, like you were saying, and I really like the way that you put things because when my company is in 24 countries, so we have 24 realities, and with that, we don't have a single way of implementing and getting the same results when we use the same AI. What we see is that besides solving a real important problem, as it was already mentioned, we need to understand how we are going to implement it, especially the training, because we are discussing about patients, but we also should be discussing, and sorry guys, about doctors that are going to use. Because sometimes we just assume that by being doctors, they will know how to use an AI tool, and sometimes they don't. And that will be the first mistake. If we don't do the proper training in the field, if we don't follow up and understand the feedback that we get from the field, the tool will never fly. Even if it is completely bulletproof for all the population and all the patients. The second thing is about our own systems, because sometimes we develop a beautiful algorithm that is proper to implement, but we forget about the systems where the algorithm is going to be implemented and also the data that we have and that will fit into that algorithm. So we have a lot of barriers that we need to face before we understand if the algorithm or if this tool is going to work. And what we have learned is that all these components, and especially the training and doing a proper follow-up on the field, is key for a success. And I'm going to just give you a small example, and I know this will sound very silly, but it's a fact. We were rolling out one of our tools, and in a specific hospital, the tool was not being implemented at all. And so the first reaction is, doctors are being resistant, so they are not using at all. That will be the first management answer to the problem. But somebody decided to go to the hospital and try to understand what happened. And what happened is that this was a specific hospital in a specific country, and there was a login issue. So the doctors were never able to log in. That's the first step, right? You need to log in. So we need to go to human factors if we want to understand why AI sometimes doesn't work, or we need to go to human factors if we want to make sure that AI is successful.
So one final round of questions from me for the four of you. As we progress from hype to reality, there are a number of issues, namely about security, sharing data, which varies from country to country, varies from culture to culture. And so how do we collectively address that growing issue as well?
I can kick off if you like. You know, I think the first thing is it comes down to collaboration and not competition. And that isn't just across our organizational stakeholders, it's also between clinicians and patients. We sometimes go into these discussions and we kind of make an assumption that our patients don't want AI. Sometimes we make an assumption that they do want AI. But the key thing is we have to sit down and have some very honest discussions around building that trust. what do those honest discussions look like? Certainly for myself, it means saying that, you know, if we don't change, we may not have a healthcare system in the way that we have. If we are not more efficient and we don't transform our services, patients are going to die on the back of an ambulance. There is a risk of inertia. There is a risk of not doing things. So we have to have some real honest discussions. And that then feeds into the things like governance and the things like safety and the things like data protection and sharing data. There isn't a simple answer though, because culturally, we are not all there yet. And you mentioned you've got 24 different countries. In the NHS, we are not one NHS, even though it might look like that. We are multiple little different pieces of a big jigsaw puzzle. And even within that, we still are not that mature that we can have that one collective conversation that really shifts the dial. Certainly, that's my opinion. I'd love to hear your thoughts, actually, on that.
Yeah, I think that there's two elements here. One is the engagement of the clinicians, and the other is the patients. Patients historically feel that they're dealing with somebody. So it's a complete mindset to be dealing with an AI machine that's telling them the answer and thinking for them and thinking it's Terminator.
Sharing information with
Yes. So I think it's winning them over, because currently algorithms are delivered by health advisors. I'm not going to sort of be disrespectful and suggest that they're the same as robots, but they are following a script and following a protocol. So, but they are a human. So I think that changing the mindset of the public that it's the same but in an automated, efficient way is one thing. I think from the clinician point of view, it's the difference between it's enhancing your assessment process and augmenting it, rather than adding extra hurdles to have you excluded X, Y, and Z. And I think it's finding the balance in the support tool that doesn't. The clinicians feel that it is improving. It's not adding extra work. They're not having to be more defensive about things that they wouldn't have thought about. And but that itself is going to be different across different clinicians. And it may be that various tools will have to have a degree of a setting of what level of decision making you're wanting to give the computer to do, or for it to suggest, so that it allows individual clinicians to tune it to their own way of working.
Sure, I totally agree. And I also would add that to be successful, we need to acknowledge that this is a very hard area to work on. We need to acknowledge complexity and not try to reduce it. And I think that for the first time, we have technology that actually allow us to easily be able to collect what's going on and to learn faster, to really understand what are the practices that do work, and to try to start measure outcomes that measure to all of us, to the patients, to the health systems. Because so far, most of the attempts to evaluate many technologies and many different ways of working has been constrained by the difficulty of actually collecting data reported by patients and data that really measure the true value of what we are trying to achieve. So I think even before thinking on very complex solutions that involve a lot of AI as a solution, we should think and employ AI as a way to finally being able to measure what measures, and so that we can all learn faster and try to achieve better outcomes from what we do.
Being the last is not the best position, but I was thinking about the word that you used, that was collaboration. And I think that in Portugal in particular, collaboration is key. We are a small country. And if we don't work together, if there is not a possibility of putting all the systems talking to each other, and it's a reality in Portugal, we don't have, even within our own NHS, we don't have our systems working or talking with each other, it will be impossible to develop a robust algorithm for anything. So also the quality of the system, the quality of the infrastructure, and the collaboration of all the operators in the system is key to make AI enable and successful.
And in the last minute that we have, I was thinking, what would make this even simpler to tell the story? So would it be a bit like having a taking an Uber in Europe, where you're okay to share your itinerary, your initial point of address, your credit card details, your name, where you're going. And then when you get into the Uber, you still have a driver driving. And then taking an Uber in San Francisco, where the process is exactly the same, but when you step into the car, there's no one driving. It's already without a driver, and you still agree and trust and go from point A to point B. Fair? Yeah. Would that be fair as a comparison?
Yeah, I think we'll get there. You know, I think we'll get there eventually. You know, but that is the dream, isn't it? The dream is that it doesn't matter where I am in the world, because my health problem is going to be the same, and the clinicians, by and large, are going to be dealing with the same problem, just in a different country. It's the systems we've created that are the challenge. So if we can streamline those systems, there's absolutely no reason why we can't make what is effectively a global challenge. Healthcare, as we started off in the day, this isn't just a Portugal problem or an England problem or a USA problem. Often we're robbing Peter to pay Paul. We're taking staff from somewhere else and bringing them into a different country. This is a global problem. And so what we need to start having is more conversations like this and looking at, you know, what other industries have done to try and figure out, actually, can we get there by reinventing some of those systems? And again, that was a point that we heard earlier on. It's not just about the technology. We've got to reinvent the way that we deliver care.
Or in UpHill's very own words, better care for all. So thank you all very much for being here today.
Thank you.
And with that, we conclude. Off to lunch we go. Thank you.
Thank you.
You, Alexandra. Thank you for all the speakers and the moderators for such a rich morning. Please allow me to just conclude with three main ideas that I think really sum up this morning. The first one is that healthcare challenges are structural, and therefore they need a long-term solution and not just a one-time band-aid. Second one is that the scale is the real test to technology, because technology is only effective when it survives the real system and it survives the work that it's being done at the hospitals. And then the third point is that trust is not a soft issue. Actually, in healthcare, trust is infrastructure. And so these tools must be designed around patients and professionals and not the other way around. Perhaps the strongest idea is that AI in healthcare should not be measured by how cool and futuristic it sounds, but what it gives back. It gives back time to clinicians. It gives back capacity to health systems and the possibility of making better decisions. So just a quick reminder before I let you all go into lunch, that if you're looking into extra team capacity, we'll have a session at 2:30 p.m. right next to the lunch area. So you're more than welcome to join. And on behalf of UpHill Health and in my name, Catarina Caria, I thank all of you for being part of this morning. I also encourage you to go and experiment our demo sessions that are just outside of the lunch area. And thank you all. I'll see you very soon.